Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out our top 200 study guide. It's a great refresher if you're out in practice, if you're going through pharmacology courses. Anybody could definitely benefit from this. So it's, again, our top 200 study guide. You can find that at reallifepharmacology.com. It is a 31-page PDF. And it's filled with some of the most important things I've seen show up on pharmacology exams throughout my career, as well as a lot of those things that actually happen in real-life practice. All right, well, we are going to get into the drug of the day, and that is Moxifloxacin. Brand name of this medication is Avelox, and this is classified as a fluoroquinolone antibiotic. More specifically, in school and throughout my career, I've always heard this medication as more of a respiratory fluoroquinolone, and I'll explain the reason for that, but I want to cover the mechanism of action first. So topoisomerase, this is an important enzyme for maintaining bacterial DNA structure. Okay, so what moxifloxacin does is it inhibits topoisomerase, and specifically topoisomerase 2 and 4, so the different subtypes. Topoisomerase 2 is the primary enzyme responsible for maintaining that DNA helical or superhelical structure. Okay, and that maintenance of managing that structure of the DNA is absolutely necessary for replication, transcription, repair, and ultimately kind of growth of the infection. So this is an antibiotic for infection, obviously, and it is considered a broad spectrum antibiotic in general. It's got some coverage on gram positives. It's got some coverage on gram negatives. Also has decent anaerobic coverage as well. But I want to go back to that point of it being a respiratory fluoroquinolone. So the differentiating factor there is medication like ciprofloxacin doesn't do as good a job at covering for strep pneumoniae, specific bacteria. Moxifloxacin and levofloxacin do a better job of covering for that bacteria. And that is a very, very common bacteria for respiratory pneumonia type infection. So that's why it's called a respiratory fluoroquinolone. So with this medication's broad coverage, you could imagine that it can be used for a variety of infections. Community-acquired pneumonia, skin and soft tissue infections, abdominal infections, and a whole host of other kind of unique infections as well. Animal bites, those type of things can be treated with this medication as well. You may see it in pelvic inflammatory disease, peritonitis, osteomyelitis. Again, might not be the first choice you'd use for all these infections, but it is a potential option if our first-line agents for some of those infections aren't available, or they're maybe not tolerable for a patient. So, good alternative type medication. Now, in practice, I don't see this medication used a ton, and there's probably a couple of reasons for that, but the one big one, when comparing it, I guess, to levofloxacin, which I see a lot more of, moxifloxacin tends to have a higher risk for QT prolongation. And that's probably one of the biggest differentiators with levofloxacin, and likely why you don't see this medication used as much as well. I also think there is less familiarity with it, as far as prescribers aren't that comfortable with it compared to Levaquin or levofloxacin, which tends to be used a little bit more frequently. And I believe that's also due to the fact that I believe it was generic before moxifloxacin. Don't quote me on that, but again, that provider experience and familiarity with levofloxacin is much greater, and prescribers tend to have a greater comfort level with levofloxacin compared to moxifloxacin. And again, coupled with that maybe higher QTc prolongation risk associated with moxifloxacin, that's really the primary reasons why you probably don't see this medication used quite as often. So obviously, adverse effect profile, I alluded to QTc prolongation. Moxifloxacin does carry the warnings that other quinolone antibiotics carry. So increased risk for tendonitis, tendon rupture, peripheral neuropathy, central nervous system effects like agitation, paranoia, and suicidal feelings. Again, these are all underneath that boxed warning. There's also one other boxed warning for patients with myasthenia gravis. It may actually worsen that condition, so it's generally recommended to avoid this medication in that setting. As far as maybe more common and less severe adverse effects, certainly some GI upset can happen. Dizziness, headache, those type of things have been reported. Photosensitivity has been reported as well. I would say it's not as big a deal as something like Bactrim, but it has been reported there as a potential concern. A couple other things to think about with moxifloxacin. So being a broader spectrum antibiotic, there probably is some risk associated with increasing C. diff risk. So if you found a patient has had recurrent C. diff or something along those lines, moxifloxacin may increase that risk a little bit further there. And then the other kind of patient background thing I pay attention to, other than QTc prolongation, is psychiatric history. If you've got a patient with anxiety, depression, psychosis, neurological type disorders, moxifloxacin may increase the risk of those things. So always got to weigh that risk versus benefit when we're making a clinical decision with a patient and potentially using this medication. One last one I'll mention as far as kind of adverse effects and precautions. Moxifloxacin has been shown to throw off blood sugars a little bit. Have seen cases of hypoglycemia before. So if you've got a patient, particularly those that are maybe taking insulin or medications that increase the secretion of insulin, so sulfonylureas, for example, we may be a little bit more at risk there for hypoglycemia. So definitely pay attention to that. And when somebody has an infection, it's always a good idea to educate our patients to try to, maybe be a little bit more diligent about checking blood sugars, monitoring for lows and things of that nature. So definitely pay attention to that with moxifloxacin as well. So those monitoring parameters, QTc prolongation, so you could monitor an EKG in that type of setting. I'm particularly more concerned if patients have risk factors for QTc prolongation. I will definitely talk about other medications coming up in the drug interaction section, but we got to think about electrolytes as well. So patients that have low potassium levels, they have low magnesium levels, for example, this can all increase the risk for QTc prolongation, ultimately arrhythmias down the road. From a pharmacokinetics standpoint, let's talk about a couple of things. So first and foremost, it comes as IV and PO, and so you may get into the situation where we want to convert from one dosage form to the other, and a question to ask is, well, what's the absorption of this medication from an oral standpoint? And absorption of moxifloxacin via the GI tract is very good. It's upwards of 90%. So generally, we can just simply do a 1-to-1 conversion of IV to PO if we're switching them over. So that's a good one to remember. And then with the dosing as well, it's 400 milligrams once a day. And the reason it's once a day is because the half-life is pretty long of this medication. Half-life is in the neighborhood of 12 hours, give or take a couple. So that's another important piece as far as dosing and pharmacokinetics. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, NAPLEX, BCMTMS, geriatrics exam, go check out meded101.com/store. We've helped thousands of pharmacists pass their board exam, and we can absolutely help you too. In addition to great study materials for pharmacists, we've also got clinical books on anything from drug-drug interactions, drug-food interactions, case studies, clinical pearls in relation to polypharmacy, tons of different books for tons of different folks who need to learn pharmacology. So again, go check that out if you're a nurse, pharmacy technician, pharmacist, med student. Definitely a lot of different resources there that can definitely help better prepare you to learn pharmacology. All right, wrapping up, let's get into drug interactions. So QTC prolongation. This is always something with moxifloxacin that I want to be thinking about, paying attention to. We're going to be monitoring that EKG, but we're also going to be looking out for medications that may worsen this. So I immediately go to antiarrhythmics, medications like amiodarone, for example. Antipsychotics are notorious for prolonging the QT interval. Medication like citalopram, so that's a SSRI antidepressant. I'd encourage you definitely to go back and listen, search and listen to that podcast on reallifepharmacology.com. Zofran, ondansetron. This is a medication used for nausea and vomiting. Also can have some QTC prolonging type effects. And there are many, many more medications. Always a good idea to double check and look that up. And of course, monitor that EKG if there's any concerns there. Next thing I'll mention, I alluded to already, insulin. Sulfonylureas, moxifloxacin may increase that risk for hypoglycemia. Typically, I would say we don't do things proactively with this interaction, but very, very important in my mind to at least monitor our patients and educate our patients about this possibility if they have diabetes and they're taking medications that lower blood sugar. Binding interactions. So with the oral formulation, much like levaquin, much like ciprofloxacin, aluminum, iron, zinc, magnesium, antacids, multivitamins, these all have potential components that can bind up that drug. And it's recommended 4 hours of separation, so give moxifloxacin 4 hours before or 8 hours after giving those supplements. Now, with moxifloxacin, only giving it once a day, hopefully that's not too difficult to find that separation, but it is really, really important to do that so we make sure we're getting adequate absorption and adequate concentrations to treat the infections that we're trying to treat. Steroids, so corticosteroids like prednisone, these can increase the risk for tendonitis. So that's an important thing to note and pay attention to. And then one last one I'll mention is warfarin. So vitamin K antagonists like warfarin, moxifloxacin may increase the anticoagulant type effect of warfarin. All right, well, that's going to wrap up the podcast for today. If you enjoyed this episode, found it helpful, do me a huge favor, leave a rating review on iTunes or wherever you're listening. Share us with friends, colleagues, classmates, pharmacy students, med students, nursing students, anybody who could benefit from some pharmacology education. I greatly appreciate that. If you got comments, suggestions, mededucation101@gmail.com or connect with me on LinkedIn, Eric Christensen, PharmD, BCPS, BCGP. Also support the sponsor, meded101.com/store. I greatly appreciate that as well. With that, I'm going to sign off. Thank you so much for listening. Take care, and I hope you have a great rest of your day.